Welcome to the Doctors Making a Difference podcast, where we help physicians to be empowered with the tools they need to be successful in medicine, in finance, and in life. Join us as we highlight doctors and other professionals around the world who are making a difference. Do you remember that time back in statistics where you thought, maybe I'll really never want to know this again? I think we've all had that. But I kind of think statistics are fascinating. It's really interesting to unpack studies, understand what they mean, and really have more specific detail about how a study actually came about. Dr. Candace Westgate is an expert on all things genomic and cancer screening. She is OBGYN, works at Community Health Network in Indiana. She's a menopause specialist and a cancer prevention expert. She has specialized expertise in cancer risk assessment, and she has a master's of public health from Tulane University, focusing on maternal and child health, completed her medical degree at Kirksville College of Osteopathic Medicine, and she completed her OBGYN training at Georgetown University in Washington, D.C. Now, Dr. Westgate is an expert on multi-cancer early detection. Today, we get the opportunity to unpack in detail some of the studies that are related to this very important emerging technology. Those of you who listen to this podcast know that I deal with cancer myself, and it's a rotten diagnosis. And I wish we could have caught it earlier. Mine was 26 centimeters by the time the tumor was identified. And so many people are impacted by cancer. It's a tremendously important disease that doesn't just affect us as individuals, it affects the entire human race. So understanding what multi-cancer early detection is, what it can do, what we know and what we don't know is really important. And I do believe this is going to inform the future. So this discussion today with Dr. Westgate is fascinating, full of dense, detailed information. And I think some people who listen to this will say, I didn't know much about it, but now I know a lot more. And I think others who are maybe a little bit skeptical about it can understand what was discovered in some of the studies that have been done on it and what is still coming forward. So I encourage you to buckle up, pay attention, and get ready to sharpen your statistics skills again. So today I'm so excited to welcome our guest, Dr. Candace Westgate. She's a director of personalized medicine at the Community Health Network and a board-certified OBGYN, menopause specialist, and cancer prevention expert. So Dr. Westgate, would you introduce yourself in more detail to our audience?
Absolutely. Hi, Dr. Crane. What an honor to be invited onto your podcast and speaking to your audience tonight. So a little bit about me. I was born and raised in South Africa and then came over to the United States when I was 18 to begin my tertiary education. I thought I was going to be an occupational therapist. I love children, love moms. And then as I was engaged in biology in undergrad, I was in classes with all of the pre-med students. And for the first time in my life, had the opportunity to think bigger. And so started to shadow a pediatrician and really got excited about being a physician. And then third and fourth year of medical school happened. And one of my attendings said to me, Candace, are you sure you want to be a pediatrician? I'm like, oh yeah, I've known this for a while now. And they were like, it's really funny because as soon as the baby is delivered and born, your eyes don't follow that baby to the Walmart. You stay with your eyes on the mother. And so that was a big turning point for me to actually do some soul searching and what is it that you want. I love preventative medicine. I love surgery and I love working with women and ended up going into OBGYN. And the purpose too was to be in happy medicine. So working with kids and then obviously as an OBGYN, most joyous time of a family's life is a good delivery.
A good delivery, yes.
A good delivery, yeah. And why do I say happy medicine? The reason why is because when I was 16, my dad was diagnosed with pancreatic cancer and 7 weeks later he passed away. And so I wanted to be the furthest thing away from cancer, the furthest thing away from people dying and suffering. And so there we go, obstetrics it was. And isn't it funny how the things in life that oftentimes cause us the biggest pain are actually the things in life where we are able to bring joy to others and we can use that pain in a completely different way. In a way we can help others instead of shying away from that. So when I actually opened up to that opportunity, I found myself passionate about cancer prevention and early detection. And as an OBGYN, we do cancer prevention, we order all of the cancer screenings for our patients because a lot of what we do is primary care with OBGYN as well. And when I was out in practice in California, I got very interested in hereditary cancer risk assessment and genetic testing and founded a program for the health system that I was working out there called the AHEAD program. So helping patients stay ahead of cancer. And the goal of it was to bring genetics and personalized genomics to the patients in the office as they were seeing their primary care, as they were seeing their OBGYN, and not constantly have to go and get a referral. 30% of patients no-show to that referral, right, in the unaffected space because of the amazing opportunity that we have as providers to prevent a cancer. When can we say that we've done that? Very rarely, unless we're finding those individuals with a genetic predisposition, mutation, BRCA, Lynch, those kind of things. And we're helping them to work through the journey of cancer prevention, risk-reducing surgeries, or significant early detection. However, only about 10% of cancers are caused by one of those inherited genetic mutations.
Mm-hmm.
So what about the rest of the 90% of the people who get cancer don't have a genetic mutation? We know the reason for cancers is so multifactorial, laundry list as long as our arm. And so to make a dent in that cancer curve is really difficult, right? We know lifestyle, genetic factors, epigenetics, bad luck, right? So many different things that impact whether or not a patient gets cancer. And for decades, we've had 5 cancer screenings, right? USDF grade A, B, or C, right? Depending on which ones we're looking at. And that's all we've had. I like the analogy of the spotlight. So what we're doing is taking those 5 cancers and we're placing our spotlight just on those 5 cancers. And sometimes we do a good job of cancer screening. During COVID, we know that fell off the cliff. We know we're doing everywhere in the US is doing horrible with our lung cancer screening statistics. But what about the darkness all around us? Because 70% of cancer deaths in the United States are for cancers we do not have a screening test for. And we know that by screening an asymptomatic individual, we're going to be able to pick up the cancer at an earlier stage and have an impact on long-term survival. Their cancer treatment is going to be less invasive, etc. So early detection is really what we're looking at here to bend that curve in regards to cancer mortality and cancer outcomes. But if all we do is keep adding single cancer screenings to our patients, what we're going to do is significantly impact false positives. And what that's going to do is cause unnecessary workups, harm, anxiety, cost to the healthcare system if we just keep doing single cancer screenings. And why do I say that? We know a single cancer screening test, the sensitivity is high, as it should be. A woman walking into an imaging center for her mammography, we want to make sure we're not missing a breast cancer if she has it, right? So that bar is set really high when it comes to sensitivity. But what that leaves us with is lower specificity and higher false positives rates, okay? Now, I got super excited when I heard about this new concept, this new paradigm of cancer screening called multi-cancer early detection. Number one, because the origin story of it actually started in the OB world. So if you don't mind us taking a little left turn for a minute and me explaining how that happened. So when non-invasive prenatal genetic testing came onto the market 15-ish or so years ago, at Illumina, they had over 150,000 specimens that the pathologists were reporting out on. And there were about 12, so only a dozen out of 150,000 specimens that had a very unique look to them and couldn't really be interpreted. And so the pathologist at that time started to look closer at the specimen and was like, there is something else going on here. What might this be? And so further investigation of that and follow-up of these moms showed that all of them were diagnosed with cancer soon after delivery. So this cancer signal from cell-free DNA is then what spun out the company called Grail. The test is called Galleri. And so the next 7 years was spent in R&D trying to figure out what is this cancer signal, how do we find it, and how can we use this as a test to be able to pick up cancer at an earlier stage. So it started in cell-free DNA testing, non-invasive prenatal genetic testing, and from that evolved into a multi-cancer early detection screening test. And so I saw an amazing opportunity for all patients, not just those with a genetic mutation that my clinic was centered around, but for all patients to have better options and improve their ability to screen for those cancers that we don't have screening tests for. But we have to change our paradigm because, as I said, we can't just keep adding more single cancer screenings because then a patient's just going to spending their whole life going from one test to the next. It's going to take too long and too many false positives. And so here's where the paradigm shift is in regards to multi-cancer early detection. So what we're doing is screening one individual for multiple cancers at the same time instead of a individual for individual cancers and multiple of them.
Like, just backing up just a little bit, I think that's really interesting. You wanted to choose medicine that brought you joy. And there's a lot of, I think about, I'm a family doctor. I tell my colleagues a lot of my job is sad. We're talking about people with significant illness, but I deliver babies too. And that's this joyful thing. And when you can diagnose somebody with cancer early enough that there's something you can
Correct.
do about it and prevent that from progressing or prevent that from metastasizing, that while that's a difficult diagnosis to make, that is joyful to say, hey, we found this. We found this early enough that you can do something about it. And I appreciate the sidebar of describing how multi-cancer early detection came about. I want to ask, maybe just back up a couple steps. Some of the physicians in the audience know exactly what this means. Some may not. And some of the audience members who aren't doctors are like, what's cell-free tumor DNA? What is that? And just from my understanding, and I'm going to kind of quiz you about it as an expert, most cancers are derived from either from a mutation that occurred, either a germline mutation that they or something that they inherited, or something that came about because of something that they were exposed to or something along their life path environmentally, something that made that mutation occur. So there are known genetic mutations that are associated with a variety of cancer. And if you can know what those sequences are and detect them early, you can gain a signal and find out those who carry that and those who don't. Is that correct?
Almost. We're close. But here is where the science behind this came in. What they did in the R&D phase was look at multiple different genetic markers within the DNA, so actual mutations within the DNA, as well as methylation patterns. And so what they found in their discovery phase was that the methylation patterns were actually more indicative of the cancer than those point mutations within the double-stranded DNA. So these are methylation groups. And what happens is that there's a shared cancer signal. So a shared change in those methylation patterns for that distinguishes a cancer cell compared to a normal tissue cell. And then because of embryology, there's additional methylation patterns that actually say this is lung, this is liver, this is pancreas. So with this kind of multi-cancer early detection test, looking at methylation signatures, we're not only able to identify a cancer signal, but we're also able to identify the cancer signal of origin. So where should we go and look in the body? And this is important, Dr. Crane, because if we're just getting the answer of, oh, there's a cancer signal, then we have to go look in the whole body like for a needle in a haystack. And so that ends up with whole body radiation, whole body imaging that, and CT scans are not always the best option for certain cancers when it comes to diagnosis. And there's a lot of radiation for an individual. So there's certain companies out there and their MCED test doesn't give a cancer signal of origin. So you have to go straight to whole body imaging to try and find the cancer, because there are a few companies now out on the market as well, whereas others using this methylation technology are actually able to provide a cancer signal of origin.
Yeah. So multi-cancer early detection, MCED, is a coming technology. I come across this every day. My patients, hey, Dr. Crane, I saw on TV or I read somewhere on the internet or somebody told me about that fancy test that can screen for dozens of cancers. Can you order that for me? And where we are in 2026 and where we're going with that are important discussions, because some doctors are like, I don't want to get this needle in a haystack sort of thing and be obligated to order and authorize a PET CT scan for the entire person. So I guess one of the things we might unpack a little bit is, what do we know about multi-cancer early detection right now as far as a screening modality? And what are some of the ongoing studies right now that might shed some light on where this is going and how it might be actually clinically useful in the future?
Yeah. We right now are in a very interesting and very exciting phase of it. There's actually been the first randomized controlled trial of an MCED test. It's called NHS-Galleri, looking at over 140,000 individuals in England. So the national health system there, double-blind randomized controlled trial. And following these individuals, and the individuals were getting yearly Galleri testing for 3 years, and then following them over time. The goal with this study and for the NHS was to show a decrease in stage 3 and stage 4 cancers. Now, anyone who is paying attention to the space saw that in February, there was news headlines all over say the Galleri test failed. It didn't decrease stage 3 and stage 4 cancers. And then we all had to be on pause because we're waiting for the actual study to come out, not just the media's interpretation of it. And then at ASCO this year, there were 2 really great presentations on 2 amazing research studies. So Pathfinder 2 and then the NHS-Galleri randomized controlled trial. And from that, we were actually able to glean a significant amount of valuable information about what this would look like in the general population and what the results were from this. So Pathfinder 2 was the largest interventional MCED study conducted thus far in the United States. There were over 35,000 participants. They were aged greater than 50, looking at 42 different American healthcare systems. So really broad sampling across the US. Blood was drawn. It was tested for the MCED test at the Galleri. And then we get 2 results from this test: cancer signal detected or no cancer signal detected. If a cancer signal is detected, because this is a screening test, then a diagnostic workup needs to be done based on that cancer signal of origin. And either cancer is found or cancer isn't found. All right. I'm going to pause us for a minute because us as clinicians obviously need to understand the performance metrics of what these tests are doing. And here is where the difference between an MCED test and a single cancer screening test really comes in. So with an MCED test, specificity is chosen, not sensitivity, because we don't want too many false positives with this kind of test. So specificity for this was shown to be 99.5%. So false positive rate is 0.5%, extremely low. Okay. The next performance metric for an MCED test that is really important and different than our single cancer screenings is this thing called positive predicted value. So I like this metric because when I'm sitting counseling a patient about the results in the clinic, this is really what matters. So if a patient is sitting in front of me and we got a cancer signal detected, what are the chances that when we do that diagnostic workup, we're actually going to find cancer for that patient? That's what the PPV is, right? And PPV for our current single cancer screenings are less than 10%. USPSTF. So this is where we live. This is what we're used to, okay? For an MCED test, the Galleri test with Pathfinder 2, positive predictive value was 62%. So if you get a cancer signal detected, you keep looking until you find a cancer, right? And it outperforms our current single cancer screening tests from that perspective, okay? Good news, this test, the Pathfinder, so back to Pathfinder 2, US-based study, this test was looking and was implemented in the intended use population. So this is not a clinically validated study that was done many years ago. This was looking at putting this in real world, in our clinics, in the patients that we're seeing on a regular basis. And how is this test performing? Because tests can perform pretty well in a case-controlled study. But when you're putting it out there in the real world, things can change drastically. So the performance metrics of the Pathfinder 2 were very similar, if not better, than the clinically validated studies, they're called CCGA. And in the clinical validation, the positive predictive value there was around 42. And in Pathfinder 2, it was up to 62%. And similar specificity. So that hasn't changed. Specificity of 99.5%. So a 0.5% false positive rate. But interesting with this Pathfinder 2, what they found was that there was a nearly 3 times the number of screen-detected cancers when Galleri was added to standard of care screening. So let's pause again. This MCED technology is not meant to be or not meant to substitute our USPSTF recommended cancer screenings. this MCED technology is supposed to be used in addition to, not instead of. So when we add this to our mammograms, our pap smears, our colon cancer screening, and in the Pathfinder study, they showed there was nearly 3 times the number of cancers was detected when we added Galleri to just basic screening based on USPSTF. And over half of the cancers that were found in Pathfinder were in early stages, so stage 1 or 2. Now, thankfully, with all the updates and improvements in cancer treatments, a lot of stage 3 cancers are actually treated with curative intent. And so when we look at the stage 1 through 3 data for the Pathfinder, over 70.9% of the cancers were found in stage 1 through 3 when it came to the Pathfinder study. Okay. So what do we know about the biology of MCED testing? Okay. So first off, we're biopsying the bloodstream. Okay. And so those cancers that are growing faster, that are shedding more of their DNA, their cell-free DNA, that are closer to a blood supply, that are more aggressive, right? These are going to be cancers that it is much easier for us to pick up with a blood-based sample. So the sensitivity of Galleri as a whole, looking at all of the 50 different types of cancer, was actually pretty low. It was around 39, close to 40%. When they pulled out 12 pre-specified are the most deadly cancers that cause 2/3 of deaths in the United States. So these include anus, bladder, colon and rectal, esophagus, head and neck, liver, bile duct, lung, lymphoma, ovarian, pancreas, plasma cell neoplasm, and stomach cancer. The sensitivity there was around 70%, so 69.8%. So for the cancers that cause 2/3 of deaths within the United States, the sensitivity of this test in regards to picking them up was close to 70% sensitivity. Okay, again, the positive predictive value that was seen in this Pathfinder 2 study was around 60.3%. And overall, there's a significantly low false positive rate when it comes to this test. Okay, so moving on to some of the data that was found with the NHS-Galleri. So much larger sample size, so over 142,000 individuals that were randomized and consented, right? The interventional arm included a Galleri test run on the sample. And if the results came back cancer signal detected, then that individual was unblinded. The staff obviously were unblinded. And that patient was then referred to the NHS Cancer Diagnostic Pathway Clinic. So they didn't get us any special treatment. There wasn't a special clinic developed just for the study. And the reason for this was that the NHS wanted to see, could their infrastructure handle the potential increase in cancer diagnosis, but what would it look like with the resources that they have right now? Okay. So that individual would then go through the cancer diagnostic workup and then would either be diagnosed with a cancer or no cancer signal detected. For those that came back negative, so no cancer signal detected, they then got repeat testing next year and the next year. So for a total of 3 years, these individuals were followed over time. In the control arm, the individuals still got their blood tests, so they didn't know which arm they were in. But those blood samples are just held. They were never, the NSAID testing was never run on these individuals. Okay. Now, let's talk a little bit about the results from this randomized control trial. All right. So anytime we do a new cancer screening initiative within a population, the cancers that we find are going to be prevalent cancers, not incident cancers. And what was very staggering and what was reported to be staggering was the amount of stage 3 cancer that was asymptomatic in the British population that was found during the study. So in the first round of screening, which remember is the prevalent round, there was a 19% increase risk in the amount of cancers that were found. Okay. Then when they moved to the next year and the next year, there then was a decrease by 5% in the first incident round, so year 2, and a decrease in 12% by year 3. But when we look at a 19% increase compared to a 17% decrease over the next 2 years, that's not statistically significant decrease. Right? However, When they subpassed or looked deeper, because this data is so rich with information for us, when they looked closer just at stage 4 cancers, overall, there was a 14% reduction in stage 4 cancers after the 3 consecutive rounds. And when they looked at the 12 pre-specified deadly cancers versus all the cancers that were found, there was an 11% reduction in stage 4 cancers after the 3 consecutive rounds. So there was a decrease in late stage cancer. But unfortunately, when the trial outcomes were set many years ago, they had wanted to look at stage 3 and stage 4. Okay. So what are some other really important nuggets and very valuable information that came out of this? There was a 16% increased risk in stage 1 and 2 cancers detected compared to the control arm. There was 4 times increase in screen-detected cancers. Remember when in the Pathfinder study, they had a 3-fold increase or 3 times increase. In the NHS-Galleri study, they also showed a 21% reduction in clinically detected cancers and a 25% reduction in emergency room presentation diagnoses. And that is important to that NHS, right, one-payer system, because those are the most expensive cancers to take care of when someone's coming in through the emergency room, right? So what are the takeaways from the NHS-Galleri? Not just the headline of it failed, right? Yes, the primary endpoint was not met. So stage 3 and 4 cancer reduction when combined and looked together was not met. However, there was observed a greater than 20% reduction in stage 4 cancers in the incidence rounds and a 16% increase in cancers detected in stage 1 and 2 in that group of 12 pre-specified deadly cancers. From a safety and performance perspective, in this randomized controlled trial, the positive predicted value in the NHS-Galleri was around 62. Remember I said in the Pathfinder here in the US, it was 62, NHS-Galleri. And the specificity remained the same in both arms, 99.6%. And in the different routes to diagnosis, there was a 4-fold increased risk in screen-detected cancers when Galleri was added to baseline cancer recommendations, and a 25% reduction in cancers detected through emergency room presentation. So really exciting, fantastic research, large numbers, randomized controlled trials, as well as real-world evidence trials in the intended use population with the Pathfinder trial here in the US. There is also the REACH trial going on right now. So that is in combination with Medicare and GRAIL. And the purpose of this is to take a look at that Medicare beneficiary population, offer them the Galleri test on a yearly basis for 3 years, follow them over time. So similar to what the NHS did. And here the end point is a reduction in stage 4 cancer. And so gathering a significant amount of data because we don't have anything to compare this to, right? It's not like a Cologuard comparing it to a colonoscopy to say yes or no, you can use it or no, you can't, or what's the sensitivity or specificity. There you're comparing apples to apples, right? Here, this is a totally different technology, a multi-cancer test. We really can't compare it to where we live in our single cancer screening paradigm shift right now. So if you're a physician out there and you're curious about this, I would say there is ample evidence right now for you to have confidence that this is the future of cancer screening, and the hope for us as physicians as well as patients for a change, a bend in that curve where we're able to pick up cancers in asymptomatic patient populations at an earlier stage where we can have a significant impact in outcomes and survival.
I've talked to patients and clinicians who were used to this idea. If I do a colonoscopy, if I do a CT scan, if I do a pap test, I will see abnormal cells. I'll see polyps. I'll see nodules. I'll see something abnormal. But the thing that we all have to remember is this starts on a level that's not visual. You can't see it on a scan. You can't see it on a scope, because by the time it's that big, there are millions of cells that have that problem. And so I'm excited about this. I don't think it undermines what we've been doing in the past, because those big cancer screening programs that have been built, like you said, are important to continue. But if this technology bears out like we expect, this is something that can really change the stage at which we diagnose cancer. I've shared with my podcast audience that I've had cancer and it's a rotten diagnosis, but the tumor that I
Oh,
found was 26 centimeters by the time they found it.
wow.
I would have loved to find that when it was smaller because I
Smaller.
was
Yeah.
completely asymptomatic. And I think most patients would share the same thing. If we catch them earlier, the
Yeah.
treatment is so much better. And so I'm personally very excited about this, and I'm excited to share it with my patients. How do you frame this for your patients when you have these discussions?
Yes. Great question, right? And as busy clinicians, we can't have one more thing to add to the list of things that we need to speak
Right.
about when it comes to this. I really focus this at the time of my annual exam. I also see a significant amount of patients that are at elevated risk of cancer. And so this is an ideal opportunity for someone who has a BRCA mutation or Lynch syndrome mutation or strong family history. And I'm even counseling them that their germline genetic testing is negative. And now what? Right? Because that doesn't mean you might never get cancer. Now what? So what are the lifestyle things that we should be doing for you? What are your cancer screenings based on your age and your risk factors? And there is a new test on the market. And so I'm able to explain what this test is. Unfortunately, it's not yet covered by the majority of insurers. There are a lot of employee-based insurance programs that are picking this up. TRICARE is now covering this.
Mhm.
Medicare Advantage is covering this. So it's growing. But obviously for Medicare to cover this, it first of all needs to be FDA approved. And so Rail is definitely working on that process. But they first had to start in Congress because there wasn't even legislature. I get tongue tied on that word
Yeah,
all the time.
legislation.
Good thing I'm not a politician. Hey. For Medicare and CMS to cover preventative services like an MCED test. And so great news. Recently, the bill was passed in Congress for there to be the option of covering a test like this once it is FDA approved. So we're moving in the right direction. The science is ever evolving, and we're learning so much about the test, the way it performs, and the impact that it can have on patients. So who should get this test? We haven't answered that question yet, Crane. Yeah. So just like with any cancer screening test, if you're doing it in a low risk population or a young population, the chances are if you do get a false positive, if you do get a positive, it might be a false positive. So the purpose of a cancer screening is to find those that are at risk and screen them in the appropriate time. And so hence we don't necessarily start colonoscopies at 25.
Right.
There's age-based guidelines. So for this test, it can be as simple as age 50. Now, there are no societal guidelines out there yet telling us when and who we should order this test for. But if we're thinking of this in a logical manner based on our current cancer screening paradigms, then we know that an individual that is over the age of 50 has a 13-fold higher risk of getting cancer compared to those individuals less than age 50. So age alone is an independent risk factor for developing cancer. But we know that there are many other things that can also increase cancer risk, right? So smokers, those individuals that have a strong family history of cancer, those individuals with a known pathogenic mutation, those individuals who've had a prior cancer diagnosis and undergone treatment, we know they're at elevated risk for a secondary cancer. Specifically, those pediatric cancer survivors, those that are immunosuppressed, have cirrhosis of the liver or significant environmental exposure. So you can think of our first responders and our firefighters in that regards. So as simple as over the age of 50, or you can consider it on younger individuals who are at elevated risk of cancer. This is a snapshot in time picture of what's going on in the body. So when our organization rolled this out 2 years ago, there was a significant amount of confusion between our germline genetic program for cancer risk assessment and the Galleri cancer screening test. And so two separate things. Germline genetics tells us, is there a genetic mutation inherited by that individual that is placing them at elevated risk for possibly developing cancer in the future? Okay. This MCED cancer screening test looks in that patient's body right now, snapshot in time. Is there a cancer signal that is found? So it's the same as getting a mammogram or a colonoscopy, and it's something that is going to have to be repeated. Currently, again, we don't have societal guidelines on when that should be, but there is some emerging data that yearly testing would help to miss less people in regards to the latency of when a cancer signal can be found in the blood compared to when a patient actually becomes symptomatic from that cancer.
Yeah. So I think from what you're telling me, as a primary care doctor, over the next few years, will probably see some societal guidelines that kind of give some more specificity. But even now, if somebody wants to pay for it, or if they happen to have an insurance that
Yeah.
covers it, they could get it, especially if somebody who's at high risk, they have a family member who's had cancer, they've had previous cancer, they've had environmental exposures that put them at
Correct.
risk. And so I see this as just as like cancer treatment has become much more specific and much more focused on the DNA level of understanding what's actually going on. Our cancer screening is moving that same
Yes.
direction. And I'm pretty excited about it because I see what could happen for detecting cancer at an earlier stage. Many people say it's not if you get cancer, it's when. And,
Right.
will it
Yeah.
affect your lifespan or not? But if you can find a cancer way, way earlier, the treatments are just so much more specific and the cure rate is much higher. And so there's still some data to be found about which population group, what insurers will cover this based on cost versus benefit. What does
Right.
it do for long-term mortality or stage 4 diagnoses? And so there's a lot going on. But I think that as physicians, rather than pushing this aside and saying, this isn't proven yet, I should just ignore it. I think we should keep our eyes open because this is something that really will change the whole landscape of how we detect cancer. It's not just those 5 or 6 cancers with current screening programs. This opens the world to, like you said, the 70% of cancer deaths that are not
Yeah.
screened cancers. There's a tremendous opportunity to help our patients. So I am quite excited about it.
Exactly, Dr. Crane. Now, the challenge with us waiting for that mortality data is that we're going to be waiting over a decade, potentially get the green light that, yes, this is a good test. And so those surrogate markers of reduction in stage 4 cancers are really where the field is looking at, because we don't have 10 years to wait
Right.
in our war against cancer, right? As for a lot of physicians, they like to wait for guidelines to come out. And that's definitely the safe thing to do. But is it the right thing to do with our patients, knowing how long it takes for different guidelines to come out? So just like you said, I would highly encourage all of the physicians listening to this, stay curious, keep reading, keep looking. There is a significant amount and additional studies going on right now. Galleri itself and the company Grail has over let me get my statistics right, 380,000 participants in different research studies right now looking at this MCED space. And there are multiple other companies that are developing MCED cancer screening tests. So this field is blowing up, which is really exciting because it's moving forward fast. And I'm really excited to see where we're going to be in the next 4 to 5 years with this technology.
Yeah. And just as we wrap up time, I'm thinking back to your original statement. You became interested in this because you wanted to deliver the joyful part of medicine. We found this early. Or thinking back to your story of, you said it was your dad who had
Father.
pancreatic cancer at
Yeah.
such a young age and passed away. And so cancer impacts all of us at some level.
All of us.
And so I think this is the effort of not just one company or one doctor. This is the effort of
Yeah.
the human race to figure out how can we figure out these diseases at an earlier stage and how can we make a tremendous impact. And so I just really appreciate you taking the time to share that. Thank you so much.
You're welcome. A little more on that. I don't think anyone can raise their hand without, and I don't know anyone who's had cancer, or I don't have a family member who's had cancer. Right? For me, that journey started when I was 16 and my dad got pancreatic cancer and passed away in 7 weeks. So a cancer whose symptoms are very indolent, could be a multitude of things. He spent 2 years being treated for GERD, right?
Mm-hmm.
All the
Right.
while losing weight. And then finally, when the diagnosis did come, it was too late. However, a totally different experience was my mom when I was in my 40s. She was diagnosed with stage 1B triple positive breast cancer. So that used to be a scary disease with HER2 positive breast cancer. It's not so much anymore. It was caught at an early stage because we have a great cancer screening tool for this kind of cancer. And we have years of research that has got us to the place where we have treatments, right? And we know that not all breast cancers are the same. And then it hit me. And I was not paying attention as a physician. I was busy. I was 38 weeks pregnant. had been ignoring a mole that had developed on my left posterior calf muscle in pregnancy and just happened to nick it with my nail at 38 weeks pregnant. It wouldn't stop bleeding. I went to visit my friend across the street who was a dermatologist. She sent it off for pathology. I went into labor 3 days later. My son was 3 days old, and I get a phone call from her to say, Candace, I'm so sorry, this is melanoma. So I hightailed it into office because she hadn't seen me in over a year, and I've got multiple atypical nevi. My Irish skin doesn't help that one bit. A second melanoma was diagnosed. I lost half of my eyebrow as a result of that. Hudson was 2 weeks old when I went in for almost 8-hour surgery, needing lymph node biopsies and plastic surgery and all of that to reconstruct part of my face. Thank God it was stage 1A or 1B. But that cancer shouldn't have happened, right? If I was staying up on my cancer screening, seeing my dermatologist regularly, removing atypical nevi, it wouldn't have progressed in that manner. But again, a cancer that we can find early, like cervical cancer, we can find that early because of a good screening tool. And so the passion in me to help more people with early cancer detection so that they can live a long and healthy life with their family is really what drives me. It's also helped me to reinvent myself. I don't deliver babies anymore, and burnout was becoming a reality. And instead now my practice is all menopause, helping to prevent suffering in women, and as well as the director of personalized medicine and working on cancer prevention and early detection. So I am so blessed and so honored to be in medicine right now. And the heartache at the age of 16 has turned into my biggest blessing and gift that I can give to patients now.
Dr. Westgate, thank you so much for sharing those tender thoughts and those personal experiences. And I have taken some inspiration from this. How can people get a hold of you if they want to follow your work or say, I've got to ask Dr. Westgate a question?
They can find me on LinkedIn. I'm not heavy on social media, but I will leave my work email if they have specific questions in regards to multi-cancer early detection. I'm really passionate about this, so happy to engage with anyone who's interested.
Thank you again for taking the time. I really appreciate it. Keep in touch.
Definitely. Thank you, Dr. Crane. Great to be with you today.
Thank you. Thanks for tuning into the Doctors Making a Difference podcast. And thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician, and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only, and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel, and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.